Good afternoon, everyone. And it is afternoon. It's after 12 noon. My name is John Carethers. I'm the chair of the Department of Internal Medicine here at the University of Michigan. It's my pleasure to welcome you today to our first webinar series that will happen every quarter during this year. This is our inaugural session. I want to thank all of you online for supporting internal medicine with your donations and contributions. Today, we will engage you and our community with experts from internal medicine. And today, we will highlight the division of geriatrics. Our department is ranked 6th in the country, and our geriatrics division is ranked 12th in the country by U.S. News and World Report. Geriatrics in palliative medicine is one of our 13 divisions. Their topic and expertise is in care of older adults. And today we're going to talk a little bit about the challenges related to COVID-19. We have some wonderful speakers today from the Division of Geriatric and Palliative Medicine. Dr. Lona Mody, who's the Amanda Sanford Hickey Collegiate Professor of Internal Medicine. Dr. Grace Jenq, who's Associate Professor of Internal Medicine and Associate Chief Clinical Officer for Ambulatory Care Services. And Adam Marks, who's Associate Professor of Internal Medicine and Associate Professor of Pediatrics. And I am going to now introduce Dr. Ray Young, who's the Jeffrey B. Halter Collegiate Professor of Geriatric Medicine, Director of the Geriatric Center and Institute of Gerontology, and Chief of the Division of Geriatric Medicine, who's going to talk to you today on learn from our past, lead in the present, and prepare for the future. Dr. Young.
Great, thank you, John. Many thanks for the introduction, and on behalf of the division and the Geriatric Center, I also want to extend my welcome and also appreciation for the opportunity to have this conversation with you. Well, some of the things that we are doing during this COVID-19 pandemics. So if you can go to the next slide. So as John mentioned, the title of my talk is Learn from Our Past, Lead in the Present, and Prepare for the Future. And so this slide speaks about our past, present, and future as well. So when Dr. Carethers and I were little kids in the 1960s, and in the left-hand side of this graph, the world had almost 3 times as many children under the age of 5 than there were adults 65 and older. And if you fast forward along the curve in here, looking at the population's change, now in 2020, for the first time, there are now more adults over the age of 65 than those under the age of 5. And that's for the first time in the history of the world. And as you move forward, continue along these curves, you can see that this trend will continue at least for the next few decades. Next slide, please. And as we get older, we also had the pleasure of being more likely to develop a host of chronic and acute diseases. And indeed, as this graph is showing, that aging is the most important and common risk factors for many, if not most, common illnesses. If you go to the next slide. So this is also true for the COVID-19 infection. Looking at this data, you can see population adjusted cases of number of COVID-19 patients by age group. And as you can see from the left size graph, that particularly those who are 65 and above, 75 and above, and 85 and above, particularly susceptible to the infection. And not only do they get the infection more easily, but they also have a much higher mortality rate, as is shown on the right side of this graph. So please, next slide. And I often equate our division and our center to a four-legged stool with interdisciplinary clinical care, research and policy, education, and social work and community programs as a structure that supports our overall mission to improve the care of older adults. And because of time, I will only be highlighting a few of the clinical care and research work that we're doing in relation to the COVID-19 pandemic. And then I'll then pass on the discussion to our other panelists. So the next slide. So our older adults and our older patients have many unique challenges in pretty much all in all the clinical care setting during the pandemic. The social isolation, the inability to exercise, etc., are particularly hard to this population. And in the outpatient arena, most of our clinical care had to be provided virtually. And the challenge for older adults, much more so than the younger population, includes their ability or inability to do video-based care visits. And oftentimes we ended up having to do a lot of telephone clinic visits. And this is a particular issue for many older adults with either age-related memory decline or some form of Alzheimer's disease and related dementias. We know that in general, adoption of technology starts to decline, particularly after the age of 75, although of course, as people are more used to technology over time, this may change. But as a whole, I think most of our older patients understand that they're particularly susceptible of it and are willing to practice social distancing and self-isolation. And as I mentioned, this really hits our old patient hard, especially as the pandemic drags on not just weeks, but into the months. And our clinic, as well as our social work and community programs, have to put in a lot of extra effort to help take care of these populations. While it's not possible to tell you all of the different things that we're doing there, I would suggest that you may want to go online to our Turner Senior Resource Center. If you just Google that, you'll find it. And as well as our OSHA Lifelong Learning Institute, that to showcase some of the effort of what we can do. And the newsletter talk about some of the resources that are also available for those, not just our patients, but very much the caregivers and the family worry about them. In addition, please, in the arena of the inpatient care, our physicians are also very much involved during this pandemic. We have an acute care for the elders that helps us look after older folks in the hospital. And the University of Michigan health system, as a system, we do not own any post-acute care facilities, and but we work with many different ones that are out there. So we develop a lot of different things that can be helpful, including a hospital care home, which is headed by Grace Jenq, and a house call program that we'll be talking about, and also palliative care, hospice care that Dr. Adam Mass will also be talking about in the last slide. And Dr. Lona Mody, who will be speaking next, will talk a lot more about the research and policies. We are involved in defining the ethics of clinical research involving older adults in this era, and arguing that in some cases it will be not be a good idea to exclude older adults in research during this time. And we're involved in vaccine trials and other things to help improve the outcome of patients with COVID. So with this, I want to pass on to the next panelist, Dr. Lona Mody, the Amanda Sanford Professor of Internal Medicine, one of our faculty in the division. Lona?
Yeah, thank you. Thank you, John. Thank you, Ray. And thank you all for joining us and discussing this very important, perhaps the most historic event in our professional and personal lives. By the way of my introduction, I've been a faculty member with the University of Michigan and at the Ann Arbor VA since 2003. And all my work focus passion has been to understand and prevent infections in older adults. My other interest, of course, includes mentorship, career development, and visual arts. Next slide. So when I think of infectious diseases, I think about a host, in this case, older adults, particularly those who have medical conditions such as diabetes, hypertension, obesity, or minority populations who have been impacted really severely by our COVID-19 pandemic. I think about the virus, which in this case has been highly contagious compared with other viral pandemics in the past. We hear many stories about infections spreading within the families and in close quarters very easily, and oftentimes, by asymptomatic and pre-symptomatic individuals. All of this comes to head in congregate settings such as nursing homes, where short stay patients who are there for a couple of weeks getting rehabilitation, wound care, antibiotics, mix around with long stay, vulnerable, frail, older adults who consider nursing homes their homes. Compounding that, we have several structural process staffing issues, even without a pandemic, where our staff members in nursing homes are very stretched and often work in multiple facilities. Next slide. So I got interested in pandemic planning efforts back in 2007 and 8 as a very junior faculty, along with my colleagues at the University of Nebraska, including a medical student who was actually spending some time with us that summer. We sent out surveys to nursing homes in Nebraska and Michigan to understand their level of pandemic preparedness, thinking about the H5N1 influenza scare at that time. This paper was then published in a premier journal, the JAMA publication. What we saw was that over 50% of nursing homes in 2007 had absolutely no plan for pandemic preparedness. 25% had a plan, but it was rolled into their overall disaster preparedness. And the other 25% just had a separate pandemic plan, which we were happy to see. We then published a recommendation of what an ideal preparedness plan, pandemic preparedness plan would look like, along with Dr. Sandro Cinti, who is our collaborator in infectious diseases. We modeled a few scenarios. We pointed out the weakness, the incredible weaknesses in this sector, as well as an immediate need for collaborative planning and dialogue between nursing homes and various stakeholders. These two papers at that time were really well received and picked up by a lot of media and lay press. Next slide. Fast forward to February of 2020, as soon as we learned about the first outbreak in a nursing home in Seattle, we immediately dusted off our previous survey, pulled out our other study materials, and sent out another survey to our Michigan nursing homes, just to understand where they stood. This was right before the first case hit our state. We learned many nursing homes responded, and we learned that they were indeed better prepared in 2020 before the actual start and declaration of pandemic than in 2007. They were already thinking about staffing. They were starting to stockpile PPE and other infection prevention supplies. They were providing staff education. Their communication lines were much better with the hospitals and public health offices. They had much better access to lab facilities than before. However, they wrote notes and notes about being worried about staff and PPE shortages. Our team continued to worry about these nursing homes, especially Michigan nursing homes, because we knew we have done a lot of work in this space. And we sent off a second survey at the peak to see where they were and what was going on. And again, we got a very good response rate, and nursing homes started to see a sudden drop in occupancy. They had incredible, 3/4 of them had staff shortages and PPE shortages. There was confusing guidance coming their way from the state, the CDC, the HHS, CMS. They were facing testing issues. There was confusion regarding hospital transfers, and they were facing psychological consequences of the visitation policies. Next slide. To top it off, our nursing homes were portrayed very negatively in the media. But as Dr. Young just mentioned, we do have our dedicated divisional faculty who provide care to 4 local nursing homes. And during this particular peak of the pandemic, we started seeing COVID-19 cases, the first one appearing on March 23rd. So what you see on the slide is a typical epi curve. On the y-axis is the number of cases, and on the x-axis is the time. So we started seeing cases on March 23rd, and we got together our colleagues from the SNF, our infectious disease collaborators, and our laboratory services, and immediately did a facility-wide testing at all the sites, with results being available to the nursing home within 24 to 48 hours. What that did was that the nursing homes were able to immediately cohort off the positive patients and thereby spare the other residents and patients who were negative. This kind of proactive coordinated steps were critical in rapidly responding and limiting this outbreak. We could minimize burden on the healthcare system, saved cost, and this data and these strategies that we implemented will inform the state's response as well as national response with a publication in press at our Geriatrics journal. Next. This set of projects have also positioned us and prepared us to lead several other initiatives, which are outlined in this upcoming projects, including transmission of SARS-CoV on environmental surfaces, helping the state prepare for a moderate fall surge, developing a sweeping research agenda in healthcare epidemiology. I'll be leading that initiative nationally and with international collaborators. We will be helping develop a national nursing home clinical trials infrastructure. I believe that there's a huge gap between our public and our academia, and I'm hoping that in future I would be the one bridging that gap using virtual infection prevention educator modules. Resiliency is very important during pandemics, and we are developing several programs to improve resiliency of our healthcare professionals through medical arts. And it is critical, absolutely critical, to prepare the next generation, particularly in pandemic preparedness and crisis leadership, and we'll be developing several initiatives in that regard. I'm going to stop here, and I'm going to hand over to my colleague, dear friend, superb leader, Grace, you're on.
Thank you. Good afternoon, everybody. I just want to introduce myself. My name is Grace Jenq, and I am the Associate Chief Clinical Officer for Post-Acute Care here at Michigan Medicine. Next slide. So before I came to Michigan, which was 4 years ago, I actually worked as a hospitalist on the geriatric acute care for the elderly unit. And for 15 years in New Haven, Connecticut, I grew accustomed to taking care of patients in the hospital. But when I moved to Ann Arbor, Michigan, I decided that I would change it up and I wanted to try a different clinical setting. So I moved into the post-acute care world. So for the last 4 years, I've worked at 4 of the local skilled nursing facilities to provide subacute rehab care for patients who are recovering from a hospital stay. And I've also worked in the home setting. And this area of post-acute care is one that I think that deserves more attention. We've traditionally thought of patients being taken care of in the hospital or they're taken care of in the clinic, but I would encourage everybody on the line to think outside the box and to think about how we can provide care for a vulnerable population who really don't necessarily need either the hospital or the clinic, and maybe we can do things more in the home. So in the pre-COVID time, seems so long ago, but I just wanted to share that about 40% of Medicare beneficiaries went on to use post-acute care after a hospital stay. So they either went to skilled nursing facilities for rehab, and that's where I practice now, or they went home with home health, where a visiting nurse would come out to the house. You might have a home health aide every couple of days, and you might have physical therapy or occupational therapy. So 40% of Medicare beneficiaries went on to these type of places to get care. And that cost back in 2014 approximately $60 billion for Medicare fee-for-service spending, and that was about 20% of Medicare's spend. Next slide. So as you guys are all aware, because I'm sure many of you read the New York Times and other news, that COVID really has rocked the boat in the post-acute care world. And back in April, the New York Times headline stated their death pits. Virus claims at least 7,000 lives in US nursing homes, which is about 1/5 of US virus deaths. And then in July, it went 40% of all US deaths were due to deaths linked to nursing homes. So that really caught the attention of a lot of people, both in the healthcare setting as well as individuals such as yourself, consumers, family members, patients, etc., that maybe the nursing home isn't the right place to get post-acute care. And certainly things have changed quite a bit, as Dr. Mody mentioned, is that if you go to a rehab facility now, you're going to encounter staff who are wearing face shields, masks, gowns, gloves, and we appear to be aliens quite often. And for those who have a hard time understanding what's happening, it can be quite scary. Patients are now expected to be on isolation after they come out of the hospital for 2 weeks, meaning that they don't leave their rooms, and they will have sporadic visits by therapists or by nursing or by medical staff. Rehab services is completely different in this setting now. Whereas they used to go to the gym and do communal type of therapy, now it's mainly limited to one-on-one in their room, potentially, or in the hall. And like I mentioned, it is quite scary with all of the protective personal equipment, the PPE that we wear to protect our residents, our patients, as well as our staff. It is quite a different setting. Next slide. So, like I said, healthcare providers have had to really rethink about, well, what are we going to do? If we can't send patients to the nursing homes for rehab, we need to come up with different ways to take care of patients. And so here at Michigan Medicine, we've really thought a lot about how to provide the right type of care at the right place, at the right time, and ultimately at the right cost. And we want to make sure that we are taking into consideration the patient's and the family's goals. And that's what I want you guys to think about on the line, is how can we think outside of the box, and how can we provide more continuous care along the continuum over time. So I'll be sharing just in the next few slides what we are currently doing. You can switch to the next slide. So right now in post-acute care services, we have Michigan Visiting Nursing, which provides certified home health nursing, along with rehab therapists, social workers, and home health aides for a short period of time, maybe 2 to 4 weeks in the home. And this is not everyday type of service, but this is provided through commercial or through Medicare and payers. And so this is just a temporary type of service to help patients recover from a hospital stay. We also have a house call program that I want to speak very highly of, and this is a group of nurse practitioners and social workers who come out to the patient's home and can provide transition of care visits and care management visits after a hospital discharge for those who can't make it into the clinic. We help manage medication changes, we help address social determinants of health, and we do this with the specialists and the primary care providers. And then lastly, I want to highlight home med infusions, which traditionally has been able to give medications such as IV fluids or IV antibiotics in the comfort of patient's home. We also provide tube feedings. If you're not able to swallow food on your own, we can provide enteral feedings to patients at their home or any other alternative site. Next slide. So I want to share something that's new in the post-acute care setting, which is patient monitoring at home. And you can see in the slide, we are partnering with Health Recovery Solutions and providing patients with cellular tablets and Bluetooth scales, blood pressure cuffs, O2 sat monitors, thermometers. And we're allowing patients to take care of themselves at home with providing graduated support after a hospital stay. So if you think about it, in our traditional care, we have patients monitored in the home. They're checked in by a nurse every few hours. They get their vital signs taken every 8 hours. And then we send you home. When we send you home, nobody is checking your vital signs anymore. Nobody is calling to see how you're doing. And there's a voltage drop in terms of care. And I'm convinced that because of this voltage drop, we have lots of people who end up being readmitted to the hospital. So this patient monitoring at home system allows us to provide graduated care after a hospital stay. It allows for vital sign input, symptom surveys, and nursing check-in for questions. And our post-acute care providers coordinate an assessment, and we also coordinate our care with your specialists and your primary care providers. Next slide. Another model that I'm going to just mention briefly is a hospital care at home model, which we're piloting with Blue Cross Blue Shield. We are targeting elderly patients who may not want to be in the hospital. And if they have something that we can potentially treat at home, such as congestive heart failure or pneumonia or urinary tract infection, we're going to try to do that in the comfort of patient's home. And there have been lots of great outcomes in the literature showing that patients love this type of care. It lowers the rates for readmission, it shortens the length of stay, and overall, it provides cost at a lower care, and it's a major satisfier. So we're gonna be doing that over the course of next year. Next slide. So like I said before, we really need to be thinking outside of the box to think, how can we provide care for our vulnerable elderly patients, not necessarily in the hospital, not necessarily in the clinic, but potentially in the comfort of their home with wraparound services that we can provide in post-acute care. Next slide. This is just a figure that shows all of our post-acute care services that we can provide in the setting of the home, or if need be in the rehab facility. And I will end here and we will entertain questions later on. At this point, I'll turn it over to Adam Marks for palliative care for COVID patients.
Thank you, Dr. Jenq, and thank you everyone for tuning in today. My name is Adam Marks. I'm a professor of palliative medicine at the University of Michigan. I do both adult and pediatric palliative care consults. I'm also one of the faculty ethicists for the hospital, do bioethics work for Michigan Medicine. And today we're going to be talking about, briefly, I'll be talking about palliative care for COVID patients. Next slide, please. So just as a brief reminder for everyone, when we talk about palliative care, we're talking about a subspecialty of medicine for people with a serious illness to focus on quality of life. And so my team and I meet with patients who may have advanced cancer, advanced lung disease, and rather than focusing on the disease itself, we try to focus on the whole individual and every day ask, what can we do to make this day as good as it can be? Recognizing that a serious illness does not just have physical components, but also emotional, spiritual, and cultural components. Practically speaking, then, our actions fall into three main domains. We do symptom control, so managing the pain of an advanced illness, managing dyspnea, shortness of breath, nausea, help with communication to make sure that you are having your questions answered in a way that makes sense to you. Because oftentimes medical providers struggle to convey complex concepts in a succinct and understandable fashion, especially when you may not just have one doctor involved in your care, but multiple, your cancer doctor, your heart doctor, your lung doctor. Are your medical teams communicating in a clear and unified fashion? And then finally, palliative care does a lot of work around difficult decision making. When you have an advanced illness, sometimes the path forward isn't entirely clear. And does it make sense to pursue that 18th round of chemotherapy or that 13th heart surgery? Are these interventions actually helping you live in a way that you find valuable? If so, wonderful. If not, what would your care look like without these interventions? Next slide, please. To Michigan Medicine's credit, I will say that very early on in pandemic planning and disaster preparedness, it was identified that palliative care is an essential resource. By definition, a disaster means on some level that our needs are outstripping our resources. And so we will have a variety of people with very serious illness for whom cure may not be an option. And how can we continue to provide compassionate, thoughtful care for these people? So in our initial surge, providers such as myself, our nurses, our social workers, our chaplains were deemed non-redeployable. We was recognized the essential role that palliative care providers would play for our sickest COVID patients. Next slide, please. Symptom control for COVID. So very early on, our palliative care providers at Michigan Medicine, in conjunction with palliative care providers across the state and across the country, developed tools to manage the symptoms associated with COVID. So while you were being treated for your pneumonia, while you were being treated for your infections, we were there to manage the symptoms of this illness. So making sure that you feel comfortable with your breathing, making sure that your cough is managed if you're having fever, But just as importantly, if not more importantly, is acknowledging and managing the psychosocial distress that comes with this unique infection. No surprise, when this illness is all over the media, when it is all anyone is talking about, even if you yourself have a relatively minor case, it becomes a very scary thing. And when we are socially isolating, particularly here in the hospital, when in those early months and weeks, we were not allowing any visitors. So your normal supports, your spouses, your children, your friends, your family, not allowed to visit, that psychosocial distress of the illness ratchets up significantly. And so thinking again, how can we manage not only the physical manifestations of this illness, but the profound emotional, spiritual, cultural aspects as well. Next slide, please. Along those same lines, the communication challenges were again unique and immense. Many of our patients who were sickest with COVID were on some form of life support, like mechanical ventilation, for days, weeks, in some instances even months, greatly impairing their ability to vocalize and otherwise communicate. In conjunction with our interpreter services program here at Michigan Medicine, we helped to develop a variety of communication tools specifically for COVID patients who otherwise have a difficult time verbalizing. So our message boards, pain, shortness of breath, fever, please call my family, I have questions for my doctor, to aid in that communication. Not just communication though, between patients and their providers, but patients and their family members, who they may not be seeing for weeks again, or even months at a time, with our visitor restrictions in place. And so not just thinking about phone calls, but how can we help this critically ill patient FaceTime with their loved ones, taking care of patients who hadn't seen their children in months, their young children in months, and how can we help them engage as a parent, a crucial role for them that they can't engage in when they're ill in the hospital here. And then also thinking about, again, the challenges that come up when you don't just have one doctor managing your care, but multiple in the hospital, because we know that COVID comes along with a variety of complications, such as renal impairment, occasionally heart disease. And so when you have your ICU doctor and your lung doctor and your kidney doctor and your heart doctor, ensuring that the communication to these socially distanced support people, right, your spouses, children, other family members, is clear and consistent in a way that people understand. Next slide, please. And finally, briefly talking about the difficult decision-making that often comes up. Early on, so much was unknown about this disease. How can we communicate uncertainty? We are hopeful that we can get your loved one better, but we are worried we cannot. And when there's so much unknown, how can we plan for that? Again, the isolation from support, none of us make decisions in a bubble. We make decisions with our support system. And when we are removed from that, how can we support that? And then the moral distress that comes along with this. And I define moral distress as when you know what the right thing to do is, but you can't do it. And so the distress of family members. Why can't I be at bedside caring for my loved one the way I want to, but also for our medical providers, right? In our initial surge, a great deal of stress among those bedside providers because of the limitations that we had in place. And how can we bring the best of ourselves to support patients during this most difficult time? And that does it for my section. So thank you for your time.
Thank you, Dr. Marks. And I want to thank Drs. Young, Mody, Jenq, and Marks for their wonderful comments. I forgot to mention at the beginning, we are now going to a panelist to answer questions. And if you want to put your question into the Q&A box on the bottom right of your screen, click that and type in your question. I will try to read your question and have specific panelists try to answer your question. We do have some questions that came in prior to the panel, and so I'm going to start with the first one. The question is regarding the acute and short-term care setting. I'd like to know if you think the pandemic is accelerating the trend towards single-room occupancy in a meaningful way. So I'm gonna try to address that from the hospital side. The University of Michigan, in particular Michigan Medicine, we've always had single ICU rooms, largely for the individual care of patients. At our hospital, we have approximately 120 shared rooms currently out of 1,066 beds. The plan has to move all those to single rooms. This is irrespective of any pandemic, and that was going to be taken care of when the new inpatient tower was going to be completed. During COVID, obviously, as with any other infectious disease, we certainly try to contain the contagion. And this is true if someone presented with signs and symptoms of Ch.B. or any respiratory illness, that we would put them in isolation, particularly with proper airflow. So, and this is, so our drive is to have all single rooms, and I think this may accelerate this around the country. And I would say yes, for those patients in the long run, all the beds will be single, particularly at U of M, and that's the thought. And I don't know if anyone wants to address that from a nursing home perspective, but I would say one last thing, that in the old days of pandemics, and this goes back 100 years, but maybe even a little bit earlier than, later than that, that when some people had like illnesses before we had all these big hospitals, we used to put them in groups together. You know, if you had influenza, everyone went into a big single room. And this was the thought about us making a field hospital if the pandemic wasn't contained as well. So I hope that partially answered that question. I'm going to ask the next question. Regarding the long-term care setting, this person writes, I'd be curious to know if there are ongoing studies evaluating measurable health outcomes resulting from pandemic-related visiting restrictions and the much needed opportunity, much reduced opportunities to interact with family and loved ones. Maybe Dr. Mody might answer that. I think Dr. Marks did answer a little bit of that, but Dr. Mody?
Yeah, I can briefly address the concern, because that has been a major issue and major sort of event that has led to psychosocial distress in both the patients and the families, not being able to see a loved one. I know that there have been studies now published on the risk of delirium, functional decline. I personally worry about pressure ulcers and urinary catheter use due to reduced care, in-room care provided to our residents and patients in nursing home setting. I know that there are groups interested in understanding anxiety and depression in NIH-funded studies. And I know that there are task forces that are set up at both state and federal level to address some of the psychosocial consequences of visitation restrictions.
All right, thank you. I'm going to take a question from the Q&A. And maybe this is for Dr. Young. Geriatrics as a field appears to be shrinking. What can be done to change this trend?
Well, this is a great question. This is not something that is new. Over the years, there have been many initiatives to try to improve the number of board-certified geriatricians, and I would say that they have met with mixed successes. For us at Michigan Medicine, what we do is to build up a very robust fellowship program. So to become a geriatrician, you need to have training in either internal medicine or family medicine already. And in addition, then you do extra training in the fellowship to become a geriatrician. So we have the largest fellowship programs in the state, and we do our best. And those who go through our fellowships, we track to see where they, and by and large, many of them do stay within the state of Michigan to provide care locally. We also relied a lot on philanthropic support to help us build the program in order to attract junior faculty who can become future leaders in geriatrics, so that they themselves become leaders. And so our strategy is to support a lot of junior faculty to develop into future leaders.
All right, Thank you. I'm going to ask the next question, and this one I'll direct toward Dr. Marks. This person writes, wondering how best to support what to say those diagnosed with cancer at any age, but particularly even younger ages, 30s and 40s, also, that they have survived cancer. Also wondering how large institutions will address growing palliative needs given the large aging boomer population.
Boy, great questions. I'm going to start with the second one. And so the question is sort of how to support growing palliative care needs, as you saw earlier, thinking about an aging population. And as we age, we are living longer with more illness. And so you can imagine then that the need for palliative care support to increase. Very clearly, the answer cannot solely be to train more palliative care subspecialists. One of the statistics I like to trot out at cocktail parties, which is why I don't get invited to cocktail parties, is that there's one cancer doctor for every roughly 120 patients with cancer. There's one heart failure specialist for every 180 patients with heart failure. And there's one palliative care specialist for every 10,000 people with a life-threatening illness. And so the answer then is to train up every medical provider's sort of primary palliative care skills. So just like you don't necessarily need a cardiologist for every individual who has hypertension, I want every medical provider, physicians, nurses, social workers, respiratory therapists, PAs, NPs, to feel comfortable broaching conversations with people about advanced care planning. And so answering those simple questions of, if I get so sick I can't speak for myself, who's going to make decisions for me? And what does that person need to know about me to make the decisions that are right for me? I want every provider to feel comfortable broaching conversations of, gosh, it sounds like you've been back and forth to the hospital a lot over the past year. Does this plan of care still make sense? Is this helping you live in a way that you find valuable? I want every provider to feel comfortable managing the basic symptoms of an advanced illness. And then to think about, boy, when do I now need this subspecialty team to come in for this complex communication, complex decision-making? And so it's a big thing that we're doing here. We likewise have a fellowship program where we are training subspecialists. But when I'm associate director of that program, and I tell all of my fellows, I want them to be subspecialists, I also want them to be able to proselytize palliative care to a wider audience. And we've integrated a palliative care curriculum in our internal medicine program with our other School of Nursing colleagues in our social work school as well. And so are working really hard to train up that next generation of medical providers to be confident in some of these primary palliative care skills. The second question, which is, boy, what do I say to someone with cancer, is a big one as well. And it's probably easier to answer what not to say. And so what not to say is to try to bring it back to yourself, which some people do. I think that sort of this natural socializing instinct is to say, oh, you have this experience, I have a similar experience too, let me share that with you. And sometimes that's a little diminishing. Oh my gosh, you have cancer? Oh, gosh, a couple years ago, I had a polyp on a colonoscopy, and that was scary. Like, that's, a little less helpful. I see what you're trying to do. You're trying to foster connection, but it can sometimes seem a little dismissive. What I have found helpful is to simply acknowledge the emotion of the situation. Oh my gosh, I'm so sorry that you're going through this. I can't imagine how this must feel. If it's someone that's close to you, also what's not helpful is asking people, what can I do to help? Because you're asking them now to expend mental energy that they may not have to say, oh my gosh, well, I guess I need someone to mow the lawn and maybe answer mail and maybe clean my house, because everyone always says the same thing, right? Nothing. You know what? I don't need anything right now. Because even the process of trying to think, well, now I have to organize this. So I would say, so volunteer things. If you identify a need, I'd like to come mow your lawn this weekend. How about I bring over dinner? How about I do X, Y, Z? So come up with concrete suggestions of things that you can do. I also find it helpful, some of our small talk instincts. How's it going? How are you? Can feel overwhelming. And so sometimes keeping it much more focused. How's the day going today? All right. How are you right now? That can be in a more encapsulated sort of way of approaching people that it's a little bit easier to answer. Today's a good day. Today's not that great. Then the sort of global, hey, how are you? Actually terrible, thank you for asking. But if you Google, how to approach people with cancer, you'll find a variety of resources. In one of my earlier slides, I had a website called Center for the Advancement of Palliative Care, capc.org. There's a lot on there that are great resources for family members of someone who's faced with a serious illness, not just cancer. And I encourage you to check that out.
Thank you, Dr. Marks. Maybe Dr. Jenq, the field of virtual care and virtual visits has exploded. I was wondering, can you mention about the role of virtual visits in geriatric care in the post-COVID era? Particularly, the geriatric population has variability on technology, so I was wondering if you can address that.
So in our clinic setting, we've had a little bit of a harder time getting our patients up for the virtual visits in the clinic setting. So that requires patients to be on the portal, which requires them to go through a series of steps in order to engage in video with the provider. So that's been a little bit challenging. I think, Ray, you had mentioned that the adoption is about 15% of our patients in internal geriatrics. But I'll tell you this, when I give patients a tablet, like I mentioned before, with this patient monitoring at home, which has really big icons that say, press here to connect with your nurse, or step on scale, and the scale automatically weighs you in, or your blood pressure cuff automatically takes your blood pressure, the adherence is actually really high. And the vast majority of our patients who are using this patient monitoring at home kit are over the age of 61. And we've had 3 people over the age of 95 using it. So lots of folks who are able to use it, who are elderly and quite savvy with technology. But I think a lot of it has to do with just getting accustomed to it and having somebody to be able to walk you through it. And I'll fall into that category too. I can't get my Wi-Fi to work at home half the time. So, it's just how easy you're able to adapt to these things.
Well, thank you. Maybe Dr. Mody for this question, this is over the Q&A. Of the COVID-19 deaths, particularly for those over age 80, how many could have been saved if they didn't have a DNR? Oh, that's a tricky question.
I think it's a very tricky question. The statistics that people have said is that over the age of 80, mortality is upwards of 80%. It is really high mortality if they did not have a DNR, maybe even higher than that. So it is hard. And having said that, we always hear about anecdotes of those who did not need to be ventilated. They come out okay. Once you go on ventilation, that's when the situation is really dire.
Yeah.
And one comment I would just like to also make is that we often think that DNR means that we don't do anything, and that really isn't the case. All geriatricians, all internists, all surgeons understand that do not resuscitate is at the very, very last bit of life where your heart has stopped and your lungs have stopped breathing. But up to that point, we can provide a lot of interventions. And so even nursing home patients who developed COVID, DNR didn't mean that we didn't take care of you. We really did everything we could to take care of you, but stopped just short of doing sessions, cardio, shocking somebody or putting a tube down somebody.
Very, very good, very important advice. Dr. Young, I gave grand rounds a few weeks ago, but the one question is, what's the latest information about increased risk for those taking ACEs and ARBs? Those are blood pressure medicines, of course, and as well as blood type A.
Yeah, so this is a really common question that we get quite a lot. And John, I'm sure you did, and any one of you who go to the community to give any talks nowadays, this seems to be a question that came through. So a little bit of background is that the COVID-19 virus can enter the host cells through the receptor angiotensin converting enzyme 2, the ACE2. And so the use of ACE inhibitors and ARBs have been associated with upregulation of this receptor in some of the tissues in the body. And so the concerns is that some people feel that maybe that would be a problem The science is really quite complicated, unfortunately. So, for example, some feels that the difference in the ACE pathway and response between children and older adults, for example, maybe that's why older adults have worse COVID-19 outcomes. So my answer today, as we get more information over time, is that I'll refer you to the American College of Cardiology, American Heart Association, and the Heart Failure Society of America have issued a joint statement earlier in the pandemic about use of ACE inhibitor and ARBs, and that this is not really suggesting that this is not really an important, the use of these medications is not consistently associated with any COVID-19, either diagnosis or mortality. And the most important thing I would say is that please don't stop taking your ACE inhibitor or ARBs without talking to your doctor. And if you're interested, go to JAMA, Journal of American Medical Association, 2020. This year they have an article. We can send you the link later on, perhaps, if you're interested in hearing more about this.
So what about blood type A?
So blood type 8 is another interesting thing too. Since, thinking about, and again, a little bit of background, the ABO type blood typing has been around since 1901. And the ABO blood type have been linked to many illnesses, including cardiovascular disease, cancer, and also susceptibility to some infections, including the coronavirus responsible for the SARS outbreak in Asia back in the early 2000s. So my answer today again is that would say that the publications that are there does suggest a possible association between blood type A and a high risk for COVID-19 infection, while blood group O may be associated with lower risk of infection mortality. Now there was a GWAS study, so genome association studies published in the New England Journal Medicine back in June, looking at almost 2,000 Italian and Spanish patients with severe COVID-19 infections. And in that analysis, they did also show the high risk association with blood type A. So maybe there is something there, but my advice is that ABO blood type, just because it's also associated with heart disease and cancer, we don't say, you never see that listed as a risk factor that you do something, but you can't do it. And that you shouldn't consider that to be prognostic as to those who may acquire the disease or not. Yeah. So again, the New England Journal of Medicine paper was published on June 17th.
Thank you. So we're now going to go get bone marrow transplants to switch up. So I agree with you. Maybe this is for Dr. Mody. This was a comment on a Q&A. So we do have some patients that are dually enrolled between Michigan Medicine and the VA, and you work partly at the VA as well. I was wondering, do you give any advice to people who might consider either Michigan Medicine options, like what Dr. Jenq was mentioned, or VA options for things like telehealth and follow-up care? And I was wondering if you can maybe make a comment on that, and particularly the person who writes this was worried about people who don't have their own devices in particular.
Yeah, I have been very proud of the VA's telehealth program. I think they have been forefront and leaders in telehealth sort of roll out even way before the pandemic. So I think that system is fairly mature from the VA perspective. They have very good, for example, CHF program that they have, a telehealth program, excellent program. We from Geriatrics have rolled out telehealth initiatives in pharmacy. The VA has also rolled out several funds now to improve telehealth after COVID era as well. So I think that is, I'm very happy with the VA telehealth program. Having said that, certainly if there are unique needs, very specialized needs that are provided only by Michigan Medicine, certain cancers, or you should probably take care of or utilize both the systems to your advantage.
Well, okay, thank you. So using both systems, and if you have predominant coverage at one, you might have to look at cost and those types of things that could go into that factor as well. Maybe we'll just do one more question and then we're going to wrap up, and I'll try to see. You know, there's been a couple of questions about, you know, flu shots and vaccines, and I was wondering if, I don't know if Dr. Young wants to comment, or maybe whoever raised their hand first on this one. First of all, I assume all of you would recommend getting a flu shot. I don't think anyone would argue with that, so I'm not even address that. But do you, although we're learning about vaccines, and there's, you know, there's some novel vaccines. There are the traditional vaccines that are using protein for you to generate antibodies. There's now these new messenger RNA vaccines, which inserts the message in your own cells and you make the antigen. Do you have any comment based on our current knowledge on what's going to be better versus not better, particularly for an elderly patient? We may not have enough information.
Right. So I think that's the problem. So as Dr. Carethers mentioned, there are so many vaccines out there. There are at least 90 vaccines in trials, and at least 9 that are in phase 3 trials, and not all of them are in the US, and some, like the Moderna one that has gotten a lot of press, is a mRNA, messenger RNA vaccine, and the Pfizer one, Pfizer BioNTech one is moving to phase 3 here. It's also an mRNA vaccine, and then the Moderna, the AstraZeneca is the adenovirus vaccine, and so on and so forth. So ultimately, you know, I think we need to find the results of this clinical trial to understand the safety and efficacy. We all heard, I think, how recently the Oxford AstraZeneca vaccine got placed on hold because even though it is using the adenoviral vector, because of a single case of transverse spondylitis, and so while in the UK they have restarted the trial, in the US is still on hold. I think one of the things I'll mention that we can't really cut corners in this trial, and also I will also encourage people to participate in one of the COVID-19 vaccine trials. And University of Michigan Medicine is involved in going to be more than one over time in the next few months. And ultimately, the other thing related to the elderly, we got involved as a group in these vaccine trials in part because many companies and the government understand this particular disease preferentially affects the elderly, as I mentioned earlier. And so we need in the trial to have sufficient number of adults to be able to demonstrate efficacy, just like the flu trial, the flu vaccines, for example. There is now the high-dose flu vaccine that are quadrivalent rather than a trivalent vaccine. And this is the one that people over the age of 65 should get this year. And the post-marketing experience is going to be also very, very important because every clinical trial has limitations about who can get into the vaccine. And I call these elderly-like creatures because they are older by age, but then nothing like the patients I see in front of me because they don't have all the comorbidity conditions, et cetera, et cetera. So I will suggest that it's important to also look at that.
Thank you, Dr. Young. So I'm going to wrap up here. There was one question about remote care for new patients out of state, but I think that has to do with physician licensure. Most of our physicians are licensed in state, so to care for out of state, you need a state license in that state. I want to remind everyone that this event has been recorded and you'll be sent a follow-up email. I want to mention that we will have future webinars about once every 3 months. The next one is scheduled for December. Date will be forthcoming and the topic will be forthcoming, and it will likely be related on infectious diseases. I want to thank everyone again for trusting your care here at Michigan Medicine, as well as your philanthropic dollars to our Department of Internal Medicine. And we hope that the details provided to you today from our geriatrics panel, our esteemed geriatrics panel, was informative to you. So I want to thank you, and I hope you have a good rest of the day and week.